We're here with Myron Cohen at the International Conference on AIDS down here in Cape Town, South Africa. That's
There were many lines of evidence to support the idea that treatment is prevention. I won't go over all the lines of evidence, and obviously I'm a believer that that's likely true.
It seemed logical. Yeah.
It's plausible.
Yeah.
So we started a trial called HBTN-052, which is ongoing now, of discordant couples. The index case in the early arm, we'll call it, receives triple drug therapy. They have a partner who's HIV negative with whom we know they're having sex several times a month. They've been cautioned to use condoms and so on and so forth, but there's still a risk of transmission because of imperfection of human behavior. And the study is designed to challenge the hypothesis with almost 2,000 couples, 1,750 couples in 9 countries over 7 years. Why is the duration important? Because we anticipate very early benefit of ART. The first couple of years, we would be shocked if there were a lot of transmission events. But maybe in the 3rd or 4th year, we'll start seeing transmission events more readily and with resistant viruses. As people start having more trouble with their therapy, windows of time where they're not switching therapy sufficiently, et cetera, et cetera. So this is a real world trial that's ongoing with about now almost 1,300 couples enrolled in year about 3 of 7. Now, I tell you about the trial only to juxtapose that against the kind of, I think, important and positive mentality. People really want ART to serve as prevention, okay? And so at this meeting, you see a massive movement towards ART is prevention. ART will work as prevention. And I think there's 2 statements to make. It probably, over some period of time, we will probably see a benefit. The question is, what's the magnitude and durability of the benefit? And the second question is, how do we inform an individual couple? This is quite important. The Swiss, led by my own trainee, Pietro Vernazza, made a statement called the Swiss statement, saying, in people who are, if the index case is reliably suppressed in their blood, then and doesn't have an STD and feels pretty well, then the chance of a transmission event is so rare that they can have unprotected intercourse. That raised a lot of consternation for reasons that are obvious. When you're suppressed in the blood, we don't know you're suppressed in the genital tract. Furthermore, you don't get tested the day before you have your sexual event. You know, you don't run to your drugstore, get a HIV viral load test in your genital secretions and run back to your apartment. So we have a lot of caution about how we counsel couples. So we're hoping from clinical trials we'll get some idea of the magnitude and durability of benefit of ART as prevention to inform modeling, to inform the best drugs to use, to inform how to counsel couples, and to kind of prepare for the future.
So do you feel that we should, where do we go from here? Do we take it another step?
Yeah, I think we should. I think that there is no reason we shouldn't anticipate that we're going to see a positive effect of ART for treatment as prevention. Again, I have, what I don't know, I am reasonably certain that we'll see a positive signal. I just don't know the magnitude and durability of the signal. While we're waiting for the magnitude and durability of the signal, I think it is indeed very wise to try and start looking at population level benefit, or preparing for trials of population level benefit.
Like
now, there's 3 or 4 trials being in preparation. These trials require a very different format and a different strategy, and they require a different belief system a little bit. They require that you identify populations that you believe are appropriate, that can be sufficiently tested, that you'll find most of the people in the population that are infected, or a lot of those people in the population. Then you will offer them treatment earlier, so that requires a belief that earlier treatment is better, which is another belief going on right now.
We're kind of learning that.
Well, again, we're learning it through both momentum and observational studies. 052, the same study, will answer the question a little more clearly, because it's an RCT that will say early versus delayed, which will be helpful. But either way, I believe earlier is probably better, as do most people in the field. So these community trials have to have a community where a lot of people can be tested. In that context, people have to agree to go on therapy very early. This is a test and treat idea. And then you'll look for community level benefit. Now the problem, then we get into a lot of other problems. We need everybody to take their drugs reliably and well, and we need to know how to measure incidence in a community, which we don't really know how to do. Okay, we don't have very good incidence testing. So we're missing one of the critical ingredients for what's called the population level studies. But do I believe we should right now be preparing population studies? Absolutely, yes. The British are trying to prepare one called PopArt, Population ART. The French are preparing a trial. In the U.S., we're likely to do a trial called Test and Treat, and all geared towards thinking about these questions in the next 5 years, given the urgency of the problem.
IFAR is currently running a survey which is going to answer, at least from a media survey type of standpoint, the question of whether we're actually going to be able to get people to buy into conceptually
Public health benefit of ART.
Right, exactly. And whether they'd feel good about that or push back or buy in.
There was a paper, I guess, an investigator has already done a study of clients, of a modest number of clients, patients, who've said, and he's asked them, would you start your ART just to make yourself less transmissible? And I think his results were very salutary. Most people said, yes, that seems like a reasonable reason for me to start the ART, although most people would like to have a personal benefit and no personal harm. And personal harm can be two kinds of harm. There can be many kinds of harm. There can be stigma harm, there can be side effect harm, and there can be a financial harm, and there can be actual disease harm. So we need to be very careful as we try and get the individual benefit and the public health benefit together, that they move in the same direction. It would be unfortunate if they move in different directions. If we end up in a situation where people feel sick while taking pills that they're not taking for their own health, but for the good
Why
of the community.
Why am I doing this?
Well, a very big issue. And it kind of gets lost in the aspirational movement and the modeling.
This is why I did it. I didn't realize the brother's doing it. But we have about 200 responses already. We expect another 200 patients. Well, right, exactly. People are living, well, actually, we did it in two ways. Because we realize there's PEP and PrEP, there's also early treatment to, like you say, for prevention. So we're looking for people who are either positive or people who are at risk category. So we have 200 right now. We may have another 200 in the next several months. So that'll be a pretty good number.
I think it's an interesting, but in the end of the day, the proof's in the pudding. The proof's in, are we going to do this, and is it a reasonable thing to do? And again, it's funny because we have to be really, really careful that we don't cross our belief systems with our data. Okay, we need enough data to be resolute in our belief systems.
Do you feel like a demonstration project would be more valuable, or at some point, or when would be a demonstration project useful?
No, I think we have to do a demonstration project this year to answer one really critical question. We need to prove we can get people into care with higher CD4 counts. This whole idea of test and treat early when we've never moved the CD4 count higher anywhere in the world is not credible. So hear me out. We need to have people discovered, detected, who get their tests and have CD4 counts of 300, 400, 500, not 200. The CDC has been collecting this data, and I will credit them with a very small increase in CD4 count of newly detected cases, but it's not a massive increase. So the test and treat requires that the test part be rolled out very quickly, and we have to figure out a strategy that makes that work. Now, I will say that it's interesting, in Uganda and now in Kenya, the door-to-door test campaigns, they find some people with higher CD4 counts. And so, but they have an advantage of very high prevalence. You couldn't really do that in the United States very easily. So we have a problem. The test part is important, the treat part is important, and then how you measure incidence in a community. Those are three separate things that all need to be accomplished for us to succeed in the community viral load hypothesis.
So would you
And by the way, one other thing that's really important. If acute infection plays a critical role in a community, we're not dealing with acute infection. And so to the extent that acute infection drives acute to acute to acute, that is lost in our discussion. Because we don't have a way right now to
identify that.
That's right, acute and early. It's a very difficult field. It's not easy. People think it's very easy. This is a really difficult thing for the reasons I said. The testing is difficult, the treatment's difficult, and the incidence testing is difficult. Three giant problems.
Well, this will not be answered with us sitting here today.
I got to go back.
But it is truly good to explore this, and I look forward to meeting you either at ICAC or the CROI.